Firstly, I just want to say thank you so much to Helen, for running the tutorial last fortnight. She did disorders of red blood cells, including polycythemia and anemia, and it was really good, great discussion. And I'm now tempted just to hand over completely full time to Helen.
I
But
need you to put all the answers though, that we want to shout at you.
I'm happy to come. I love it. But it's so nice to hear, like, it's so nice being on the other end and go, oh, yes, I know the answer to this. Like, it's actually really, you delivered it in a really engaging way.
Oh, good.
And
Good,
then
good.
sometimes, like, oh, I don't know the answer to this and I really should. I hope somebody else answers. So we're trying to get through a fair bit today, in terms of what, like, subject areas. So we're on white cells, platelets, and bone marrow today. And that actually covers kind of immune mediated diseases as well as other causes of abnormalities in those cell lines. Um, so because we've got a huge area, does anybody have anything really specific that they're interested in covering? Any cases they want to talk about or anything?
Something I'd quite like to cover, if this would be helpful to everyone, is like a bit of decision making on. I find, but this is probably going to be a very vague and very case dependent question. But when you have sort of like middle aged cat, mild non regenerative anemia, could be anything. Like they could have a bit of early CKD. You've like done FIV, FELV testing, and then you're kind of not ignoring it, but like the cat's really well. And I guess like a bit of decision making around when we just say, look, they're mild and they're not clinical, whether like empirical giving them a bit of iron is maybe a good idea, giving them a bit of iron and darbo is maybe a good idea, or when they're really mild we just leave them. Because I find that I'm often in a situation of having, not often, but it happens, where you're saying to owners, like, if it's progressive and you're at
Mm,
the point where you're talking about bone marrow biopsies, and then I often struggle with justifying it with what's actually going to be treatable that we're going to be looking for.
yeah.
If you've got like a severe anemia and you might be looking for like a precursor, IMHA or something.
Mm.
Otherwise, I struggle to know with those like vague ongoing non-regenerative anemias how far to to push for a diagnosis.
Mm. And also, I guess balancing that on how likely you are to get a diagnosis.
Yeah.
Because most of the time in those cases, if you've documented that it's non-progressive over like a month, for example, like it's probably not
Yeah.
IMHA.
Yeah.
It's probably not like a bleeding tumor if it's not bouncing around a little bit, like if it's just kind of this cat sits at 32 and that might be its normal 27 or whatever that number is, but they're not hypochromic, not microcytic,
Mm,
and there's no other kind of localizing changes on the blood tests or anything, then I would actually probably just sit on it.
yeah.
Because you really, bone marrows are like, I think we should do way more bone marrows than we do because it's so minimally invasive. Like it's really simple to do, really quick. Often do it under Domitol with just, or in cats with just a little bolus of Alfaxan,
Yeah.
local, and they wake up thinking nothing's happened. So I think we should do it more, but in that situation, it's almost never diagnostic. Um, and we will talk more about when bone marrow is, like in the bone marrow section, when is bone marrow indicated, when it's not.
Great. Yeah.
Because you sort of think, oh, could this be bone marrow disease causing the anemia? But which which cell has the shortest lifespan?
Platelets, isn't it?
No, it's not platelets actually.
Neutrophil?
Neutrophils. Neutrophils, yeah, exactly. Neutrophils, then platelets, then red cells, basically. So if you've got something infiltrating your bone marrow, chances are your neutrophils are going to go down first,
Mm,
and then your platelets are going to go down, and then your red cells are going to go down. Platelets and red cells can depending on where their start point was.
yeah.
But if the owners are committed to just doing serial blood tests, and you can just say, let's just check this again in a week and then a month, and it's stable over that time, it's not going to be infiltrative or progressive bone marrow disease in any aggressive form. It might be something that's like mild fibrosis developing over time or something like that. But okay, yeah. So it's an interesting like mashup between the anemia discussion and the this discussion because like where bone marrow is where it all happens centrally. So maybe we start at bone marrow.
Yeah.
Yeah. Okay, cool. And then it will kind of segue into conversations about other topics. Okay. Sorry, I'll just get my notes up. Has anybody actually seen any bone marrow cases that they had that were interesting, might be interesting to others in the group? No?
I had the last cat I did a bone marrow on. We actually got a diagnosis on the aspirates and it came back. It was like it was really severe. It had really, really marked neutropenia, like 0.5 maybe on blood. It's a 10-year-old female spayed British short hair.
Mhm.
And the aspirates were diagnostic and the core wasn't.
Oh, interesting.
And it was like basically came back as like aplastic anemia, like complete like there are no cells.
There are no cells.
And
Yeah,
that
wow.
was reflected in the CBC.
Yeah.
Yeah. And she was FIV positive, FELV negative. She'd been
Mhm.
FIV positive for a really long time. And essentially, like when we worked her up, it, I don't think we ever really came to the like to why this had happened. And when I spoke to diagnostics, they were like, "Yeah, you need like a drug history, a toxin exposure, like kind of thing." Or it's just sort of happened, and she kind of just lived with it, I guess.
And that's what I wanted to say, what are the toxicities and what are the viruses and things like that that can cause bone marrow failure, essentially. And there's so many and medications and stuff like that. It's probably like the chances of us actually getting to the bottom of what it was are pretty rare.
Yeah.
I have seen one with methimazole actually.
Oh yeah, yeah, I've heard of that.
And that was just a kind of surprise, because it's a medication we use all the time. But yes, cat's bone marrow did just get completely wiped out. So what sort of blood pattern would we see? We sort of talked about it a little bit, but how would you describe a hematology in a dog that you were like concerned about, or a cat that you were concerned about bone marrow disease in?
Biocytopenia or pancytopenia?
Yeah, exactly. Yeah. So that the clue that it's at the bone marrow is that there's more than one cell line affected. And most of the time, it depends a little bit what it is, but most of the time you'll see reduction in neutrophils first, then platelets, then red cells, or platelets and red cells together. There's different, and so that's most of the time when there's like something that just halts those stem cells where they are in the bone marrow, and then you just don't get any development from that point. So you're just waiting for those peripheral cells to die off to then develop those cytopenias. So sometimes you're looking at a toxicity 1 to 4 weeks prior to when you're seeing the patient when it's actually developed clinical signs. Or they might have had like an episode of vomiting or viral stuff 4 weeks before, but the actual symptoms of anemia or neutropenia and things like that aren't until we're seeing those effects. So it can be really hard to tie the cause and effect in these cases. And I usually just say to clients, like, unless there's a really clear drug history where we started a new medication and it developed, then just we're never going to know, but we're just not going to do any more drugs.
Yeah.
So,
Anna, I have a question.
Yeah.
In cats specifically, some cats I believe can have low normal neutrophils or just like sort of very low normal neutrophils, and they are normal. But if you have bloods from previous, you can always compare and say, okay, the last year also this cat was of this and this is fine. But if
Yeah.
you're doing it as the first time point, this is something that always gets me because I'm always sitting and thinking if it's like sitting at 2 point, say I don't know, 2.3 or something. And I'm sitting and thinking, okay, it's not like I don't really want to use anything, but at the same time, I don't want to ignore this. I just don't know how should I determine whether this cat is, this is
Yeah.
their normal or is this a problem?
Yeah, it's really serial blood tests.
Okay, so it has, like,
Um,
there's nothing else. There's no
no,
other.
exactly. And because cats' catecholamine levels are so
Yeah,
variable in clinical situation, the degree of neutrophil margination, remember how the
yeah,
neutrophils stick to the walls? So if they're really relaxed, they're all going to be stuck to the walls. If they've got a big burst of adrenaline, they're going to come into the circulating pool to be mobilized to where they need to go. I think that's how it works. But the neutrophil levels in a cat will vary greatly. And I've got a theory about staff members' cats because I get asked about staff members' cats all the time. The neutrophil levels are always low. And I think they're more used to the smells of the vet clinic. They're probably visited more often, or the bloods were taken in a very fear-free
mm,
way because people were like trying to be extra nice because it was a staff pet or something. And I feel like staff pets' neutrophil count's always low.
okay,
Yeah, keep an eye out for that
yeah,
if I'm right. But yeah, I think neutrophil disorders in cats are so rare on their own.
yeah,
And if it doesn't then progress to a bicytopenia or pancytopenia, then I'm probably not going to worry about it. They're not going to get an infection at 2.3.
yeah. Yeah. When you're doing serial monitoring, are you, how soon are you doing the next one? Like, are you doing it? I mean, obviously it depends case to case and what the cat is clinically doing.
Yeah.
But if the cat's clinically fine, are you happy to do it like a week later or?
If they literally come in for like a routine dental or something like that and had this change detection on blood tests, I'd probably wait a week or a month.
Yeah.
But if they've come in because the cat's off, then
Mm.
and I'm thinking, oh, could this be IMHA tomorrow? I'm probably going to say 1 to 2 days.
Yeah.
Yeah.
Thanks.
So if there's a little pyrexia or something like that, I'm like, oh, I'm not going to sit on this one. It's a very case dependent.
Yeah. Thank you.
Yeah. Um, okay. So say we have a 4-year-old male neutered border collie who lives rurally and socializes with lots of other dogs, who has kind of progressive lethargy, nothing specific really over the previous 3 weeks. It's a working dog and all of a sudden it can't work. And that's been progressing over 3 weeks. And um, you examine it and it has pallor and lots of petechiae on its mucosa. It's anemic with a non-regenerative anemia, and has a low neutrophil count at 0.8. Platelets are 20. What is your next diagnostic step in this pattern, in this dog?
I would do a blood smear next.
Good.
So I'd check the like just manually confirm the platelet count of 20.
Yeah.
And have a look for like any changes to the like the morphology of the red blood cells and white blood cells.
Excellent. So all come back morphology wise, come back as normal. And there was thrombocytopenia was confirmed, but there was no evidence of regeneration. What toxins would you be interested in asking about exposure to? That's a tricky question, having just established that there's too many.
I'd take a drug history and like if he's a big scavenger, if he's a young dog, if he's got into any of their meds. And it sounds silly, but people do go to all different vets, and sometimes you do ask, have they been to another vet and on another medication purposefully, and you don't know.
Yeah. Yeah, that's a really good point.
Just to check.
What does parvo do to bone marrow?
Oh yeah, it can wipe it out.
Yeah, it can, can't it?
Yeah.
And there's a few viruses that can do that. So it's worth asking, is there any recent like diarrhea or illness preceding this in the sort of 2 months or so preceding? What's your next step diagnostically?
Can I, in this specific case, because he's a neutered dog, can estrogen toxicity still be on the list? Because like if the owner is using estrogen, I mean, you see it more in a entire sort of dog, but would you have it on your radar
Yeah, it's a great
Good.
thought.
You would?
Really good thought. Yeah, yeah, for sure. Because there's a lot of estrogen creams
Mhm.
like for transdermal absorption, and dogs could, in theory, absolutely lick those off and develop a toxicity, or chew on the tube. Like I'm
Mm.
not sure the owners would think to tell you that 4 weeks ago it chewed on my probably wouldn't volunteer that they chewed on the
Yeah.
supplement
Yeah.
tube. So next step, testing wise, what are you going to do?
I mean, since all cell lines are involved, more likely marrow is involved.
Mhm.
So would you straight go to marrow or would you do an ultrasound? And I don't know if you're doing an ultrasound, what exactly are you looking for? Because I'm thinking paraneoplastic syndrome.
Yeah. Yeah, so you're exactly right. Ultrasound would be part of a staging process, assuming that this is potentially a neoplastic condition. But if the owners were like all in, do everything, that's the right thing to do for sure. It's definitely not wrong to do imaging because it's harmless, right? It's not no morbidity associated with it. But I don't think it's going to give you much information. It's probably going to give you a bunch of like abnormal findings that you're not going to know the relevance of until you do your bone marrow.
Mm.
So I definitely wouldn't delay doing bone marrow, and that would be my first test in this dog. And often this is where I think the clinical decision making, often people do ultrasounds and radiographs because they're not that comfortable doing bone marrows. But I would definitely do a bone marrow here.
Anna, does him being thrombocytopenic at 20 impact your like timing or decision for bone marrow?
Not really, actually. So there's a lot of literature in humans that bone marrow aspirate is not more dangerous when there's thrombocytopenia present. Well, not significantly more dangerous. It shouldn't like make you not do it.
Yeah.
And we had this conversation quite a bit in my residency. They were quite bone marrow happy, which was nice. Like the way I was trained, we did quite a few. And particularly even just staging for mast cell disease and stuff like that. Like it was just part of the workup. And so we did a lot of dogs with thrombocytopenia, and I only had one bleed, like significantly. And then even then, it was just a local hematoma, like it wasn't like a big bleed.
But you
Yeah.
can do an aspirate and a biopsy or just an aspirate?
It depends a little bit on the patient. Usually, I'll go for both, and sometimes the core just doesn't come out, or like it won't advance, or I'm not feeling like I'm in a great like position to advance it any further. And then I'll just do an aspirate.
Mm.
There's certain patients where I really want the anatomy of the bone marrow, and others where I just want the cell differential kind of thing, depending on how they've presented. So for example, if it's like non-regenerative IMHA or something like that, I just need to know whether there's precursors there or not, or whether there's like a abundance of early cells and they're then like maturation arrest or something like that. So I don't need a biopsy in those patients. Whereas with these ones where there's like loss of all of the cell lines, I'm kind of like, could there be like fibrosis that might be evident anatomically but not on an aspirate?
Okay, that makes sense.
Yeah, and then I'm more I'd be like very, very careful to line myself up to maximize my chances of getting a core. But one you're in there with the same needle, like usually I just go in, aspirate, and then advance and pull out.
Mm.
And it's so much easier when there's actually no dog there. I find it really hard. Get the needles through. Need somebody else to be my shoulders. So that's so in this dog, we're looking for something that's impacted all of the cell lines in the bone marrow. Does anybody have a nice way of thinking about bone marrow disease in like what diseases or processes can impact all of the cell lines in the bone marrow at once?
Well, I guess if your bone marrow has been your normal functioning bone marrow is being replaced by something else, so like replaced with fibrosis because now you don't have space for your functioning cells, or replaced with neoplastic cells.
Yeah. So myelofibrosis is one category. Myelophysis is where there's infiltrates of other cells that are occupying the space that the bone marrow stem cells would have occupied, space and nutrients. And then sometimes there's just aplastic in there. There's no fibrosis. There's just all the cells died.
Mhm.
And fibrosis is probably like the step on from that, like where that tissue got replaced by fibrosis. But sometimes you just like the bone marrow is not producing anything. So I found bone marrow disease quite tricky because those words were like didn't like myelophysis doesn't really describe anything to me, but does everybody understand what that means?
Yeah, I think it makes sense when you think of this, the normal cells can't function because they're replaced and competing for nutrients. I like that with neoplasms.
Yeah, exactly. So what would be the most common cause of myelophysis?
Like leukemia?
Yes. Yep, good. So leukemia describes neoplastic white blood cells in circulation,
Oh, I see. Yeah.
but lymphoma, actually stage 5 lymphoma in the bone marrow, would probably be more common. And you don't necessarily have to have circulating neoplastic lymphocytes to call it. So you can have lymphoma in the bone marrow without leukemia.
Okay.
Have you seen any leukemia cases
Um,
that don't also have stage 5 lymphoma?
um, Not that I can think of off the top of my head.
Actually, it's really quite rare.
Because the last dog I saw with that had its white blood cell count was like 50 or something ridiculous. But
Yeah.
it had lymphoma, yeah.
Did it have lymphoma? Did it? Not CLL.
Do you know how weird this is? That dog also had a pyo. So how weird is it? It came in for a pyo. Sorry, it came in for a pyo,
Yeah.
and it obviously had like this massive white blood cell count. And I was like, fine, you've got a pyo, but it is crazy. And then the guy was like, yeah, she's just a bit weird. And I was like, oh, like all her lymph nodes are also massive. I was like, well, let's sort her pyo out. And then she also had lymphoma, and the white blood cell count never came down. Isn't that weird?
Were there lymphocytes in circulation?
Yeah, she had like yeah, the white blood cell count never came down, and she had because with lymphoid leukemia, right, you have like the acute lymph. If we're just talking about lymphocytes, acute
Yeah.
lymphoblastic leukemia, which is like aggressive, they're not well, and then chronic, like
Yeah.
CLL, which they can just grumble along for a really long time.
So those dogs typically have normal lymph nodes.
Yeah. So she had she was diagnosed with lymphoma.
Yeah, right.
Once we dealt with the pyo, she had lymphoma on lymph node aspirates, and it was in her obviously she's stage 5, but it looked like it was in her spleen as well, like she had cheesy spleen.
Yeah.
And her white blood cell count, like her peripheral white blood cell count, never came down. Her
What are we talking? How high is it?
Oh, it was like 50.
Okay.
Yeah, like ridiculous. Yeah.
50, yeah. I mean,
Yeah.
it's high, but like I always thought it'll be a lot higher, like but obviously
I
not.
think they can get, can't they?
They can, absolutely. There was a case we had through the Vets North a few weeks ago that was 140 lymphocyte count.
Does that make, obviously they're unwell because, this might be a stupid question, because they're unwell because they've got neoplasia. But like surely that they must feel,
Actually, CLL,
are they well or?
they're quite well. The thing with CLL, and this is an interesting one with your pyo dog as well, any dog with lymphatic neoplasia is compromised
Yeah,
immunity-wise because their immune system just can't mount a proper organized humoral response. So you might have like one clone of a lymphocyte that produces antibodies to parvo or something, and that's its job. Or you can fight as parvo, and then everything else you're just a sitting duck for. So what they're actually unwell with is hyperviscosity.
Yeah.
Typically, so when we see clinical signs, it's actually often only when their cell counts get over 50.
Yeah.
And often it's like 80, 90, and we start to see rumbling diarrhea and stuff like that developing. And then mental dullness is what's most often reported, but obviously that happens quite gradually, and you think, oh, they're getting older and blah, blah, blah. But I think it's worth.
Can viscosity also change with high leukocytes? I thought it was always associated with red blood cells.
Oh no, absolutely. Leukocytes as well. It's much rarer to get Oh, it's probably not. I reckon we probably see hyperviscosity with white cells like lymphocytic leukemia as frequently as we see it with polycythemia. Both are quite rare. But yeah, absolutely hyperviscosity for sure. And then because the other thing is that we've presumably got higher globulins in those patients with lymphocytic disease. So that's going to add to that viscosity as well. So let's just, I like just sort of clarifying that. So bone marrow, within the bone marrow, we can have stage 5 lymphoma where there's infiltrates of multicentric lymphoma in the bone marrow, and that's causing myelophysis of the existing bone marrow cells. But then we can also get neoplasia arising from the stem cells within the bone marrow, and that's where a leukemia comes from. So, and you can have a leukemic lymphoma, multicentric lymphoma, or you can have a true leukemia, which is where those stem cells are the neoplastic cells, or the mature cells actually are the neoplastic cells. So, as Helen mentioned, we can get neutrophilic leukemia, we can get monocytic leukemia, but by far the most common we see is lymphocytic leukemia, and that's then divided into acute lymphoblastic leukemia, ALL, which is really aggressive and very short guarded prognosis, and CLL, chronic lymphocytic leukemia, which is often undiagnosed for years, and you might sort of do a blood test in a dog, go, oh my gosh, the lymphocytes are 90, and then look back and go, well, they were actually 8 a year ago, like that was too high then. And they're often sort of rumbled along for a really long time. And they do cope really well with just kind of really like chlorambucil style alkylating agents, just managing those cell counts and stuff. So what often happens is that they then progress to a blastic crisis where then the lymphoblasts become neoplastic, and that's when they become terminal really, and that can happen quite fast, but they do rumble along for several years sometimes without any clinical signs. So everyone's happy with that distinction between lymphoma and leukemia? Sort of.
Do you put leukemias on PRED as well?
Yeah, I think so.
Yeah. And they're quite diagnosable on like even a bone marrow aspirate, do you find?
Do you know what? I would do a bone marrow aspirate if they had pancytopenia or bicytopenia. But if they've got normal cell counts and very, very high lymphocyte counts, you can actually run flow cytometry on peripheral blood and avoid it.
Okay.
And same as the blasts as well. They're quite distinctive cells that can't really be anything else. And flow cytometry is going to give you that cell origin because the cells will be atypical in appearance. And sometimes the pathologist might say, oh, they could be monocytic. They could be like null cells, like very, very, very early stem cells before they've differentiated. Or the lymphocytes, and flow cytometry is what you need to differentiate that rather than bone marrow. So it's nice when you've got circulating cells. You've got all the you've got your diagnostic sample from your CBC. And
if you have a patient in that scenario with really high lymphocytes, no peripheral lymphadenopathy, will flow cytometry tell you whether that's stage 5 lymphoma versus leukemia? Would you stage those patients as well, like with imaging?
I would give the owners the option to.
Okay.
But I would also be quite comfortable. Like if I've done a good physical exam and I'm like, you know, the lungs sound nice and clear, the respiratory function seems normal, I can't palpate a massive spleen, the liver feels fine to me, like as in it's not like taking up half the abdomen, then I would be quite comfortable to say that's a CLL if the animal's well. And might say to the owners, we might need to look into this further if things change, but I want to consult an oncologist and get him on some treatment.
That makes sense.
Oh, just my little I want to consult an oncologist. I probably wouldn't make all these decisions without talking to someone. Yeah. In fact, I would. Like if the clients just couldn't do an oncologist, then I absolutely would. But okay. Anything else on bone marrow we should cover? No.
And same
Case of you don't know what you don't know.
Well, yeah. But I think the more we look at bone marrow, the better we'll get at it. But
Oh
also,
no, this was for the questions. Like for me, I'm like, I don't even have questions because I don't even know what I don't know.
yeah. And it's not something we see very commonly either. I think probably like we're so protected from it because we don't really see a lot of FELV
Mm.
here. Whereas I think like myelodysplastic syndromes, maybe that's something we should talk about. Where we don't just get like a really obvious like one cell line multiplying, but we get like kind of vague pancytopenias, and on cytology of those cells, it's not clearly neoplastic, but it's also not clearly not neoplastic. And so there's this in humans, there's this spectrum of like where we've got normal cells and then we've got dysplastic cells and then we've got neoplastic cells. And often dysplastic syndromes turn into neoplastic syndromes, but it's a really long time sometimes, and like sometimes like 5 years potentially. So we see a lot of myelodysplastic syndromes, and we see them in conjunction with some medications and viruses and things that we see commonly not in Australia, but like things like FELV, where we'll often have an anemia. Like Helen said, those cats just with that vague anemia that doesn't really do anything, doesn't really progress, or might progress like slowly, and you're kind of getting down to 15 and going, oh, I'm gonna have to do something about this, but what? Like it's not immune mediated, it's not neoplastic. What is it? And how do you treat it? And there's not very good guidelines or anything. There is a very thorough paper on myelodysplastic syndrome, which draws very few conclusions that will help you clinically. So it's interesting, but it's not highly recommended to help you with your clinical role. Essentially, most of the recommendations with myelodysplastic syndrome say try PRED, because we really don't have any other options, particularly if the anemias in particular are getting clinical, or the neutropenia is getting clinical. But yeah, there's not much else we can do. And then you don't really want to do chemo because you might suppress the bone marrow if you haven't documented that there's myelophysis that you need to then enable the bone marrow to function. So those ones I definitely want to do bone marrow on, and I definitely want a biopsy of, so that I can classify exactly what's going on in the architecture of the bone marrow. Do we have abnormal cells taking up space in there, or do we have like fibrosis just reducing space in there? Yes. So we're going to cover a little bit more about let's talk about a clinical situation we're in all the time. So you've got a 2-kilo Chihuahua, who 2-year-old, sorry. Also 2 kilo, 2-year-old, 2-kilo Chihuahua who has presented to you pyrexic, unwell, and off food, no vomiting or diarrhea yet, but clearly flat. He normally wants to eat you and decides not to this time. Pyrexia of 40.1. Nothing else really clinically other than the pyrexia. Tachycardic, meeting the criteria for like systemic inflammation. You do a blood test, hematology, no anemia, all of the cell lines apart from your neutrophils are normal, but the neutrophil count is 0.8. How do you respond? What is your assessment of that neutropenia, I should say?
Severe.
Severe, yeah. What could be
Then
good?
again, like in my head, I'm thinking, is this consumptive, destructive, or not production? Confirm that with the smear. I always want to send out to a pathologist for review. I'll look myself, but I'll also want to send it out.
Yeah, for sure. So let's talk about what the causes of neutropenia are. Consumptive, destructive. What was the other
Not
one?
like production is not enough, inadequate production.
Yeah, good. Okay, so they're the big
Sequestration.
categories. Sorry, go Maya.
Oh, sequestration as well.
Oh yeah, that's a good one. Yeah, excellent.
I'm just going to swap to my phone because I've got to leave, but I'll be right back.
Sure. Um, yeah, sequestration, exactly. So in this patient that's presented with a pyrexia, what are our two leading differentials?
Immune mediated versus infectious. Are you I mean, a 2-year-old, are you thinking, I mean, why only two? Can't you have even neoplasm on the list, like all three?
Or you could, yeah. So I guess what I'm getting at is like in this patient that seems like it's got an infection currently. Is that infection due to a neutropenia, or is that neutropenia due to the infection? So
Hmm.
how are we going to differentiate that?
Hmm. So, like, would you not want to find out the nidus of infection, like where the infection is to begin with? But
Yeah,
that's the workup then to figure
that's
out.
yes. So this patient needs to be treated for its infection regardless of where its neutropenia came from.
And you could look for bands, like you could look for left shift to see if it's like
Yes, yeah,
like aseptic versus not being produced.
yeah. So yeah, like toxic changes
Yeah.
as well, are quite helpful. So in most of the time, like, do you know how long it takes neutrophilia to develop or the bone marrow to respond to an acute infection before you'll see a peripheral neutrophilia?
Hmm. I think it can be in within a few hours.
It's rare to get a neutrophilia within a few hours. So what will happen with consumption is that marginating pool will come into circulation. So we might get a little spike, but then it's going to get essentially just shunted straight to where the infection is or the site of inflammation. So then we're going to have very few neutrophils in the blood, and that's going to provide a strong stimulus to the bone marrow. But it's actually often 1 to 2 days, sometimes 4 days before we actually see a neutrophilia. So this is big kind of area where initially, particularly very acute infections, so often gram negatives, they have a lot of endotoxin and a lot of the pyrogens and stuff, and very pro-inflammatory response. They're going to cause a neutropenia. And then over the course of the next day, those neutrophils are going to sit in normal range for quite a while before they end up actually high. And sometimes it's depending on how much consumption and how much ongoing utilization of neutrophils there is, sometimes 2 days before we can see a neutrophilia develop. So often we're in this situation, like this happens all the time. And looking into the neutropenia in this situation isn't the priority. It's absolutely finding and dealing with the infection and decreasing consumption of those neutrophils and allowing the immune system to function again. So at what point, so say you found a cholecystitis and you treated them and pyrexia resolved within 48 hours, at what point would you want to recheck the neutrophil count?
I don't know if this is overkill, but if I had a patient like that, I'd probably be checking it daily until the patient was really well.
I probably
Maybe
would
that's too
too.
fast, but
I was going to say 3-4 days because if the animal is doing clinically well, then I don't. To me, numbers don't. It's about the clinical picture. So if the animal is clinically well, I would be happy to do it in 3-4 days. Allow it to
Um,
come up.
yeah, that's a good point.
so I think probably a deciding factor for me is, do I want to send this dog home?
Hmm.
And if it's had an infection because it had a neutropenia, and I'm going to send it home with a neutrophil count of 0.4. I mean, it's going to be on antibiotics for cholecystitis anyway, but like I probably do it right before I sent it home to give myself peace of mind that it had bounced back at least. But yeah, I don't think either answer is correct or wrong. Like if they really do everything, owners who are happy with you, like, plotting several data points and really understanding what's going on, that's fantastic. CRP is also a nice adjunct here because particularly in that phase where the neutrophil count is low and normal before we get a neutrophilia, it can really help support the hypothesis of an infection or inflammation, because sometimes you're sort of looking at the patient going, clearly they're septic, but I can't make my neutrophils meet the SIRS criteria. But a CRP can help support your decision making because these patients need antibiotics, right?
Would you go down the rabbit hole? Because that's what I would do. Why did this patient in the first place develop cholecystitis? Like a 2-year-old to develop, like obviously it's coming from the gut. So does this dog now have gut disease? Like it's not immediate problem, but would you go down this track of trying to figure out why it happened in the first place? Or not really?
So most of the time cholecystitis is secondary to vomiting. So the positive pressure within the duodenum and proximal bowel pushing like against the valves basically and causing ascending bacterial infection. And I also think a lot of the time it's just wrong place, wrong time. Like a really pathogenic bacteria happens to undergo enterohepatic circulation, which is a normal pathway, and it just sets up shop and just like it's just kind of opportunistic. So I usually don't like I've usually ultrasounded these dogs, so I would go down that much of a rabbit warren. But if it looks fairly uncomplicated, otherwise I would probably leave it at that.
Yep.
Yeah, cholecystitis was a weird choice. I should have said like cystitis or something like that. Sorry.
No, this is good.
I'm making it up as I go.
I think I complicate things in my own head for nothing.
Yeah, welcome to medicine. That's your job. Yeah, is it much more simple in opto, Maya?
Yes.
Do you overthink all your patients? Is your
I
actually
do. That's just me.
Yeah. So there's an interesting it's local to Sydney for sure. Interesting syndrome in visualers. And I'd be very interested to talk to more specialists about this because there was a period where I saw like 3 visuals in a row with a raging neutropenia and pyrexia, and the neutrophil counts didn't bounce back over a week, and they all had splenomegaly, and one had the spleen removed, and it was just like diffuse hyperplasia. But there's some sort of very active like reaction going on in these dogs. And the neutrophils all came back to normal eventually, but some of them needed prednisolone. Like they had multiple episodes of this, and some of them needed prednisolone to fix the pyrexia and get the neutrophils back up again. So often we were sort of starting antibiotics and then not getting a response, and then we had to start pred because we didn't have anything else. We were assuming that must be like a degree of autoimmune neutropenia contributing to the infection. But yeah, I haven't heard of any recently, but yeah, there's so much overlap between neutropenia and infection that the clinical signs are very hard to, like, particularly with autoimmune neutropenia, which is very, very, very rare. I always think, oh, it's not that, it's not that, it's not that. And then in these dogs, I actually think it was. So I think we had the autoimmune neutropenia contributing to the pyrexia because we had that autoimmune spleen stuff going on, and they were pred responsive and not antibiotic responsive. But yeah, visualists.
Did those visuals that you saw have like a myositis? Like, because visuals get that like polymyositis thing, don't they, where they get
Yeah.
can cause neutropenia from like
Oh, interesting.
systemic inflammation, I think.
Yeah, no, and these ones didn't.
What were they presenting for?
Pyrexia.
Oh, interesting.
Yeah. And all of them had really profound splenomegaly. But I was just wondering if maybe this was like one litter of visuals or something, or like one breeder or one genetic line, and this is just like a flash in the pan that is over and is never going to happen again. But it's yeah, don't be scared of pred if you need it. If you tried antibiotics first and then pred. I'm sounding less and less like a medicine clinician. Okay, let's talk about platelets for the last 15 minutes. Is that all right with everyone? I don't really want to, I don't think we need to do lymphocytes or monocytes and eosinophils or anything, do we? No. We'll cover like eosinophilic syndromes a little bit in the pulmonary chapters, like the pulmonary infiltrates of eosinophils, which like ties into a more kind of systemic hypereosinophilia, but it's interesting interesting picture, but we'll go into that more. Not in bone marrow. So what disorders do we get of platelet function? Oh, sorry, what disorders do we get of platelets?
Like reduced platelets, so
Mhm.
thrombocytopenia.
Mhm.
True, like true thrombocytopenia.
Mhm.
On the other spectrum, you also get like thrombocytosis, and that's the bit because thrombocytopenia I know how to sort of deal with. It's the cytosis that you see that you're like, do you do something about this, or just sit on it, or what to do with it?
Yeah, no right or wrong really. Cushing's dogs have thrombocytosis. Yeah. And it ties into their hypercoagulability, but we don't usually do anything about it. What other abnormalities can we see with platelets?
Like Pathés are
Abnormalities
not
in size.
particularly. Sorry, you go.
Oh, I was going to say abnormalities in size, like macroplatelets. But
Oh,
then
good. Yeah. Yep. Excellent. And one more.
Like Pathés are not really common.
Yes. It's not common, but probably more common than we think, actually.
But how
Um,
do you diagnose that? Like, how do you know it's a Pathé?
well, yeah, we just can't test for it, can we?
I mean, you can see that the platelet number is fine, but
Mm.
then the dog's not. But I've never really seen to know what I should expect from it. Or maybe I've never recognized, I don't know.
Yeah, I've only seen a couple of times. Aside from in a research setting, I did research on platelet function at Cornell Uni, and I just saw lots of dogs with platelet dysfunction there. So in my head, I'm like, oh no, they're everywhere.
Okay.
Actually, they're not.
But maybe they are, and we just don't recognize them.
Nah, I don't think so. There's like very specific genetic disorders that cause platelet dysfunction, but because we don't really have the testing available in Australia, we're missing them for sure. So let's talk about thrombocytopenia because it's what we see most commonly. What are the mechanisms of thrombocytopenia?
Same destruction, um, um, consumption,
Mm-hmm.
and inadequate production, which I think is not that common, the inadequate production.
No, apart from when it's accompanied by
Yeah,
pancytopenia.
yeah, yeah.
Yeah. So we can almost take it off the list. If there's no pancytopenia, it's probably not in the bone marrow. Okay, increased destruction, leading cause.
ITP, immune mediated.
Good. And in ITP, what are the antibodies directed towards?
What are the antibodies directed towards?
Yeah.
What is that? GP2B something? Is that what you?
Oh, very specific. Not what I, yes,
No.
that's not what I meant. Uh, um, so they can either be directed towards platelets or megakaryocytes.
Okay, yeah.
So how would you differentiate that clinically?
Clinically? Like through bone, like I don't know if you can clinically. Wouldn't you need bone marrow to differentiate? Because you want to see if they're actually coming out of the marrow and then getting destructed. Oh,
Yeah. And whilst I'm very bone marrow happy, I don't usually do them in my IMT dogs. I don't think we need to. So clinically, the megakaryocyte directed IMT take up to 3 weeks to respond to immunosuppressants because they've got to remake those stem cells. So it's a big job to get functional platelets from the very beginning of production. So they tend to be a lot slower to respond. So typically with IMT, they've either responded between 5 to 7 days or it's not going to be for 3 to 6 weeks. So if they don't respond in that first week, I'm often sort of, I guess, saying to the clients, okay, right, be prepared.
yeah.
This is going to be a long haul one. Excellent. So that's most common. What other causes of consumption do we see with platelets?
it's DIC.
Infections definitely do it. Infections will cause consumption.
Mhm. Yep, for sure. And DIC. Yep. Probably similar mechanisms, actually. Systemic inflammation. What else?
Neoplasia.
Good.
Neoplasia is on every list.
Everything. Yeah. What's what of neoplasia?
Massive hemorrhage.
Yeah, good. Yeah, exactly. So that's like true consumption, right? It's appropriate consumption when you've got bleeding.
Like
Um,
lymphoma will do it, hemangiosarcoma will do it.
Hemangiosarcoma in particular. So remember that platelets are activated by coming past tissue factor,
Hmm.
and hemangiosarcoma is by definition a disruption of the vessel wall. Like it's an endothelial tumor, so we're going to have really disorganized endothelial cells and therefore exposure to tissue factor. So those platelets are going to get activated just on the way through. So then we get little microthrombi and little fibrin strands forming across our like irregular vessel, and it's going to chop the red cells up when they're on the way. So often we've got a mild anemia as well, and it's going to catch all the platelets. So what sort of scale of thrombocytopenia would we see in DIC or neoplastic causes relative to IMT?
Moderate, not a severe.
Yeah, typically, and obviously, like on the way to being a severe
Hmm.
IMT, you're going to go through that scale if it's IMT, but they're usually not clinical until they're very low. Whereas often the platelet count never gets low enough to cause bleeding in those neoplastic DIC sepsis kind of patients. Is that everybody's clinical experience?
I think so. I mean, the few that have, yeah.
Yeah. So typically sort of 60 to 120-ish for that kind of consumption sort of mechanism as opposed to destruction, which gets much lower. At what point do you need to worry about bleeding, spontaneous bleeding?
Less than 30,
Yeah, good.
like textbooks say, but some people also say 50, you should be on alert.
Yeah, and I guess that's because we sort of say spontaneous bleeding, like they might bleed out at home while they're lying in their bed, kind of thing, like just with normal peristalsis and normal lung movement and stuff like that. So that's spontaneous bleeding. But then in a clinical environment where there's a cannula, where there's people taking blood from the jugular, people holding up vessels and stuff, like and creating more opportunities for bleeding, and also being restrained or barking in their cages and stuff, there's more risk of spontaneous bleeding in those situations. So 50-ish in a clinical environment. When would you not do surgery if you could avoid it? At what level of platelets?
I would say less than 100.
That would be ideal. 60, I'm like chewing my nails. But sometimes in those bleeding spleens, you have to. But if it's a kind of slam dunk bleeding splenic tumor, you kind of know where the platelets are and that you need to stop the bleeding to use what platelets are left. It's an interesting kind of human perspective in that humans, there's two different forms of IMT in humans. They can have a platelet count of 10 and not bleed at all. And when they do like thromboelastography and platelet function testing, those platelets are actually hyperfunctioning. So they work better than normal platelets. And then there's other patients with a platelet count of 10, and those platelets are hypofunctioning, and they're the bleeding ones. And they don't really understand, or they understand way more than I have the ability to comprehend what the difference is. But I think we sometimes see that clinically, those dogs that are just, you can't stop them from bleeding when they're thrombocytopenic, and other dogs that they're just not really bleeding. And you're just like, okay, I suppose I can manage you as an outpatient, but it's making me nervous. So I think there's probably more that we could understand about platelets in dogs, but it's probably deeper than Edinger requires.
What's the mechanism of thrombocytopenia and hypersensitivity reactions? Like, snakes and even like bee stings.
Oh, I don't know.
Sometimes I've seen that, but I just don't know. And like with bees, but I just call it consumptive, but I don't really understand why, like how.
I think I mean it has to be right, like if because it's very acute, it can't
Yeah.
be decreased production and I don't think it's destruction. But yeah, I don't know. I mean with snakes in particular, most of the snakes have like procoagulant, like they just diffusely activate the coagulation system, and cause essentially a DIC-like syndrome. Um, like I think brown snakes might have like 10A, factor 10A or something activator in them. I can't remember. But so that makes sense for consumption, right? But I'm not sure about bee stings actually.
Yeah, sorry, it was more bee stings. With snakes, like pre and procoagulants, but bees, I've had a few.
Mm.
And then it's like they can get as low as like
Mm.
60, 70 on the machine, and then you look at the smear and sort of similar, if not exact, and then it's like, do you just sit? And I've just sat on it and they're fine then, but I'm like, I don't really know what happened there.
Hmm. Well, I mean, histamine activates platelets, doesn't it?
Hmm.
So I
Yeah.
suppose it would just get like activation and therefore consumption, just form little microthrombi.
Hmm.
Stick wherever they land. Um, okay. What else should we cover here? Oh, interesting. Any drugs that might cause decreased platelet production selectively?
Estrogen. Does that do that? No. No, I'm thinking of
More
neutrophils.
pan, yeah, more pan-cytopenia with estrogen. It's kind of it's a bit of a vague question because this drug does a lot. So myelodysplastic disorders are more common in dogs on phenobarbital,
Hmm.
and platelet disorders in particular are overrepresented in dogs on phenobarbital. So, in theory, if there's a dog on pheno who develops IMT, I'd probably look at changing medications. Because it doesn't really, I mean, they don't really know what the link is, but it's genuine IMT, which is responsive to prednisolone, but that's more likely to happen in phenobarb dogs, but as is bone marrow like level dysfunction and decrease in platelet levels. But I don't see that very often. And we know that myelodysplastic syndromes are more common in dogs than pheno. Just a drug to have in the back of your mind that we use often. What other?
Doesn't some chemo drugs also do it? Like lomustine in cats does thrombocytopenia, doesn't it? Or have I just made that up? Sorry.
I don't know. No, and lomustine I always think of as neutropenia as the main thing, but um, I don't know.
Yeah. I'll look that up.
Not vincristine. So maybe we should just pair up lomustine and vincristine to like offset each other.
Yeah.
Um, I hope nobody actually took that seriously. That was a joke. Because vincristine increases platelet number. That's why.
Yeah. Yeah.
Um, okay, what other medications could trigger IMT?
The
Well,
TMS.
cephaloxolin or cephalexin is supposed to, but I don't know if is it just a textbook thing or does it actually do it?
I've never seen it. But definitely TMS for sure, and particularly in those like sensitive breeds. Um, what about infectious causes of secondary IMT?
Dogs or cats or both?
Mostly dogs.
Like tick-borne disease.
Yeah, good. Yeah, they're the main ones, aren't they? Do you know any of?
Is rickettsia one?
In other countries, yeah, not in Australia.
Um,
Is Ehrlichia
Ehrlichia does it.
your disease? Is that the category it falls under?
Which one?
Because the sort of rickettsia disease is like an umbrella term for a few different bacteria.
Yeah,
mhm.
Ehrlichia falls in that.
Ehrlichia is
Ehrlichia,
rickettsial.
yeah, yeah, okay. And anaplasma?
Plasma. Yeah.
Babesia.
Yeah, babesia. Good. Yeah, yeah, awesome. So they're the main ones. Um, I feel like I haven't taught you anything you don't know today. Has anybody got any like last minute excellent questions? Light bulb moments?
Mm.
Nope. All right. I better clock off. Thanks for coming, everybody. And the next one is on polyarthropathies, like more kind of immune-mediated diseases, and is in 2 weeks. We'll see you then.
That's just
Yeah.
for that.
Thank you.
Thanks for coming.
Have a good
Thank
day.
you.
Bye.
Bye.